am Rachel, host and community manager here at Alloy Health. We are a digital health platform bringing science-backed, evidence-based menopause hormonal solutions direct to your door. I'm so glad you're with us here today. And if you are here, you're likely navigating some of the more confounding shifts that midlife can bring. Changes to your skin, your hair, your weight, maybe even your sense of self. It can be a lot, not just physically, but emotionally, mentally, and even socially. That's why today's conversation matters so much. We're going to talk through what's happening beneath the surface, the hormonal, metabolic, and structural changes that drive so much of what women in midlife are experiencing. And to help us do that, I'm thrilled to be joined by Dr. Deepti Gandhi, one of our phenomenal physicians here at Alloy. Dr. Gandhi is a board certified family medicine physician with over 2 decades of experience, and she's also obviously a Menopause Society certified practitioner. Her passion is helping women understand their hormone health and advocate for themselves, make informed, empowered decisions about their care. She's also a mindset coach, a speaker, and educator. So she brings this beautiful mix of clinical precision and big picture thinking to every conversation. Whether you're already taking advantage of all of Alloy's offerings or just trying to understand what's changing, this is a safe, smart, grounded space to learn. Feel free, as always, to drop your questions into the Q&A, and I will get to them shortly. Dr. Gandhi, welcome again. I'm so happy to have you here.
I'm so happy to be here, Rachel, and with everyone. Yay.
Thank you. Thank you. I'm so happy we're able to make this work. We're going to start with skin. I think for a lot of us, skin may be the first place we begin to see a shift. That moment when, makeup isn't sitting quite the same, or you can't use enough moisturizer, and it's not always about vanity. It's about recognize that something internal is changing. So we know that estrogen is key for skin integrity. But what's actually happening when estrogen starts to decline? How does that show up in the skin?
That's such a great question. And I'm so glad you said that. Skin is our largest organ, so taking care of it isn't simply vanity, right? It's kind of the first thing people see. It's the first thing we see when we look in the mirror. So it's really important to take care of it. So yeah, when estrogen declines, we start to notice that our skin is more dry. It affects the thickness, it affects the collagen. And so we certainly notice these changes. It affects the elasticity. Absolutely.
And so you talked about collagen, you mentioned collagen, hydration, thickness. So this can show up as sort of fine lines and wrinkles and sort of feeling drier and things like this.
Absolutely. People notice just their skin feels differently, like you said. They notice maybe a little bit of some laxity. As you said, when the usual skincare regimen that they use doesn't seem to have the same effects. Some people even start feeling itchy, and not
Mhm.
just on the face, but all over, right?
Yeah,
And so
I
this,
have
yes, me too, as your
yeah.
perimenopausal doctor right here.
Yes.
Yes.
Yeah. Okay. So some women get more reactive skin in perimenopause and maybe into menopause. So like breakouts, rosacea, stinging, while others sort of feel like their skin just kind of deflates. What's driving
Mm.
that?
Yeah, that's a really great point. So I think like the deflation, that might be related to the collagen, the changes, right, that we're noticing. So estrogen actually has a relationship with collagen. It helps with collagen synthesis and it helps to decrease collagen degradation, so breakdown. So when you don't have as much of it, we're not having those effects like we used to, right? And then also, estrogen is an anti-inflammatory in the body. And so when you no longer have as much of that, it gives rise to these pro-inflammatory cytokines in the skin as well. And then that is what makes it affects just kind of the way the skin behaves. There's even more vascular reactivity, which is these are kind of like the hallmarks for rosacea, for example. So we're
Okay.
more likely to develop those.
Interesting. So can you tell us a bit about how M4, to your point about sort of estrogen and how it's helpful internally, anti-inflammatory internally, how might M4 be so effective externally to the skin?
Great question. So, yeah, so M4 contains estriol, right, which is a type of estrogen. So, we have three estrogens in our body that are naturally made, and estriol is probably one of the weaker ones. But through studies and research, we find that in the right concentration, estriol can be very helpful to use topically on the top of the skin to actually help build up more collagen, help with hydration, help with fine lines.
Okay.
Yeah.
I want to ask sort of like a quick myth check, if you will, question. So, if your skincare routine worked beautifully in your 30s, should it still be working now in your late 40s, 50s, 60s?
Well, the answer is no, right?
No.
So much changes. I mean, right? There's a whole bunch of other things that are changing. So the same techniques, the same strategies, the same way of living life isn't going to work. And that comes, down to what we do with our skin as well.
Okay, thank you. Um, I hear a lot from women, say things like their skin sort of changed overnight, it's become drier and duller. No
Right.
product seems to help. Um, can you tell us any more about sort of how we can understand that hormones can indeed play such a big role in skin health?
Yeah, so I think kind of looking at the big picture of what's going on, right? And in a woman's body, who has ovaries, right? Or even if you had them removed recently, you were born with them, right? So we have to remember every single cell in our body has an estrogen receptor. And
Hmm,
so when you first get your period, that's when your ovaries start making it, right? And you have your cycle every month and not to get too technical here, but there's, peaks and valleys that are normal and regulated and that happens, right? And then we enter perimenopause, right? So that's that stage that's like 4 to 10 years before menopause, which is no bleeding for over 12 months. And so that's a long time, right? 4 to 10 years before. So what's happening in perimenopause is now the ovaries are kind of erratic in their production, right? So some days they're like making lots and some days barely any. And so your body is now, responding to this fluctuation and, inconsistent amount that we're getting. And as I said, if every single cell in the body, including the skin, which is our largest organ, has an estrogen receptor, every cell in the skin, it's
right.
obviously going to cause a huge impact.
Thank you. That's helpful to
Sure.
sort of amplify what's really going on and why that might be happening. I see some
Right.
questions have come in. Thank you so much for them. I will get to them. They're great. I just want to move on a bit to hair now. So like skin, hair loss is quite personal. It's
Mhm.
also quite emotional. And what makes it harder so often for women is they're told it's just part of getting older. Excuse me, but that doesn't
Right.
mean that it's something we have to sort of suffer through. So, from a physiological standpoint, Dr. Gandhi, how does estrogen, again, we're going to hear this word over and over today, how does estrogen loss affect the hair growth cycle? And what players like DHT or thyroid function are you looking out for with your midlife patients?
Absolutely. Such a great question because over 50% of women do notice some type of hair loss and thinning, over this transition. So it's really impactful and it's really important that we talk about it. So what's happening is with, this declining estrogen levels, right? Remember, every single cell is feeling this in our body. So of course, our scalp, our hair as well, we notice that there's this relative sort of increase in androgens, right? And so, one example of an androgen is it's testosterone, for example, right? And so that relative imbalance. So it's not necessarily that the testosterone's going up or the androgens are going up. It's just that you have less of estrogen. And so what that ends up causing is that when you have more of that relatively, you can actually get more conversion of that to DHT, what you mentioned. And there's some people genetically that are even more predisposed to that happening. And then it's the DHT that ends up causing what we call the miniaturization of hair follicles. It actually affects the phase of hair growth. So there's different phases in a hair follicle's growth cycle. And so the growth phase unfortunately gets shortened, and then the resting phase gets lengthened. We end up noticing less growth, more shedding, and then the follicles that are affected actually produce less and finer hair. So this is why sometimes people are like, hey, I notice my hair is like more brittle, it's more dry.
Yeah, that's
Yeah.
why.
Yes.
So we offer, I know at Alloy, I use it, oral minoxidil, because I also like went through this period of what seemed like much more than just sort of like your average hair shedding. And my hair was already thin. It was definitely feeling thinner. Um,
Mhm.
but for many people, using oral minoxidil can feel like a big leap. Who's a good candidate, and how do you help women weigh the pros and cons?
Sure, absolutely. So, we find there's pretty solid data that shows that in low doses, oral minoxidil can be beneficial in terms of helping with hair density and growth. Um, the concerns that I would have would be a few things. Like, so in some people, it can cause hypertrichosis, which means increased hair growth in other areas, right? So, the unwanted hair in places in unwanted areas, I should
Right,
say,
like
right?
our faces of
Like
some,
our face, right?
yeah.
Or, other places that we don't necessarily want it. It can also cause low blood pressure. They call
Mm,
it postular hypotension. So we typically recommend, being on a low dose, taking it at night before you go to
right.
bed. So it's unlikely, right? And then there's some cardiac side effects, but those are extremely rare.
Okay,
So at Alloy, we have a very in-depth intake. There's a lot of questions that we ask to really make sure it's the right choice.
right. That's so helpful. And I was thinking also as you were just talking that comparatively the topical minoxidil is sort of like was popular, I know, for a long time. I think before people got more word that oral minoxidil was like not so messy and maybe more effective, and people could sort of get in a rhythm of taking a pill every night versus using something, particularly women who may have hairstyles or other
Hmm.
products that they want to use in their hair. And so I would just mention that as well, that I think oral is just so much better.
Yeah, I mean, I think for people who, typically might have longer hair and not want to wash their hair every day, it's going to be tough to have a liquid solution that you're rubbing in. I mean, it might work well for some people, in their lifestyle, but that was one of the probably drawbacks that
Yeah.
deters a lot of people from using it.
Yeah. So I know that hair thinning also doesn't always show up the same way. It can be like temples, crown, overall volume. Is that about genetics, hormones, stress, or a little bit of everything?
I would say it's probably a little bit of everything. I mean, when we talk about hair loss or alopecia, there's several different kinds. The most common kind is called female pattern hair loss, right? And so that's typically thinning kind of in the part or in the crown area, right? Yet the hairline is maintained.
Okay. And then
Yeah.
nail pattern is that bald spot
And
that,
then receding
and then
here in the
receding. Yes, receding.
right. That's a
Yes,
little bit.
yes, yes.
Yeah.
Okay,
Yeah.
interesting. Um,
Yeah.
I was just thinking, I got a comment from someone when I was sharing about this webinar, and she said, when I started noticing thinning around my temples, I didn't know who to talk to, and that that we offer solutions like
Yeah.
oral minoxidil sort of made her feel much better about not wanting to hide, but really supporting
Hmm.
women from the inside out. So I wanted to share that with you.
Oh.
Let's move on to weight. So I think, one of the hardest parts for women in midlife, around weight gain is the suddenness of it,
Mm,
which can be like, what the hell? And also kind of where it shows up, which can also be just a surprise. Women who talk about, where did my waist go? And
hmm.
this kind of thing. And it seems almost overnight. But there's a lot more to weight gain in midlife beyond the aesthetic, beyond having to go out and buy a new pair of jeans. And I wonder if you could
Right.
just sort of unpack for us the metabolic shift that tees us up for weight changes in midlife, and really explain that it's not a willpower problem.
Absolutely. I mean, I think your last sentence, it's a metabolic shift that is happening, right? So it's not because you've changed things. It's not for lack of trying, you know. So I really like to make sure to highlight that for women. So,
Mhm.
the menopause transition marks, as you said, a major metabolic shift, right? So what's happening is the declining estrogen production actually causes a profound change in your physiology, right? So the body is in some ways compensating, for this. And that's why we see all these changes despite maybe not changing one thing with your nutrition and your exercise.
Right.
So one thing is your basal metabolic rate goes down, and that's kind of the baseline amount of energy it takes to just run the system, right? For, to breathe and for your heart to pump and work and all those kinds of things. So that goes down in and of itself.
Just by virtue of age or by virtue of estrogen declining?
Estrogen declining.
Okay.
Yeah. And then the other thing that's happening is, the body is trying to deal with this, it's noticing like, okay, there's less estrogen. So there's a shift in which the body starts to make more fat, right? And our fat, because you can make some estrogen in fat tissue. It's
Mhm.
not great, it's not efficient, it's not really the right kind, but the body's trying, right? And we
Okay.
kind of shift from what we called gynoid fat distribution to more of an android fat distribution. So what that basically means is instead of it, kind of being subcutaneous and being on your thighs and your hips, right, which is what we typically, had maybe noticed thus far as women, where we still had a waist, as you were saying, it shifts more to abdominal midsection, deposition, and also visceral fat, which is that intra-abdominal fat that's really inflammatory.
Right. And
Yeah.
that intra-abdominal fat is fat also that's sort of like surrounding and invading organs. Does it invade organs? Am I making
It
that up?
surrounding,
Okay,
surrounding.
it's surrounding
Yeah.
organs, and
Yeah.
it's the fat that will lead to unhealthy metabolic shifts. Is that correct?
Exactly.
And
Yes,
what would
yes,
be
to
an
chronic
example of
diseases
that?
like
Oh, okay.
diabetes, right? For example, some other things that we notice is that is actually that point as our insulin resistance starts to go up. So it's this fat as well as, the lack of estrogen affecting maybe how much insulin the pancreas is making, right?
Right.
The liver ends up producing more glucose. So that even causes an effect on our blood sugar regulation, and our propensity and tendency to develop diabetes down the line.
Mhm.
So there's a lot of shifts going on. I mean, if we kind of think of our body composition and we sort of focus on, okay, muscle mass, bone mass, maybe like a pie chart, maybe like a pie, if you kind of envision like, okay, muscle, bone, subcutaneous fat, and then visceral fat. So what ends up start to happen is that our subcutaneous fat is getting bigger, right? Our visceral fat is getting bigger. Our muscle mass is starting to decline, and so is our bone mass. So that's the major shift that's happening.
That's so helpful. I've never kind of envisioned it like that, and it's kind of depressing, but there are things we can do about it,
There's
right? And
things you can absolutely do
so tell
about
us
it.
about some of those things before we talk about GLP-1s.
Absolutely. So I think first it's just, knowledge is power, right? Like us talking together and with, the audience that we have today, sharing notes, learning from each other that, okay, this is a shift that happens to us, but there's a lot we can do about it. So, we have to remember food is our fuel, right?
Mhm.
Food is nourishment. So you get to choose how you want to nourish yourself, your new changing system, right? So that's going to mean we're going to prioritize plants. We're going to prioritize fiber, protein, hydration, right? And then our movement may need to change, right? The way that we move our body. Sleep is so important. Sleep plays a role in stress reduction. I mean, this is all happening during midlife
Right.
when, gosh, being in midlife is tough as it is, right? You're kind of squeezed between a couple different generations. You're thinking of your career. You might have a mortgage. I mean, you're raising children, maybe grandkids, your
Right.
elders, you're starting to worry about them. And then all these things are starting to happen. And you're like, wait, what? Why is this happening now? I had everything locked down. I was a multitasking machine, but now this is happening. But, I really like to reframe this as a time to really reprioritize yourself, right? These symptoms force you to do that, and it's an opportunity.
I love that. Let's pivot to GLP-1s for a minute, and I
Yeah.
want to sort of um, ask you to take a moment to explain MHT versus GLP-1s. And I think there's a little bit of confusion out there that remains that,
Mm.
well, if I'm taking MHT, isn't that going to help me with my weight and sort of
Right.
keeping it down where I wanted it? So can you explain a little bit of that?
Absolutely. And I think I just want to share there is so much noise out there, when it comes to
I don't know.
hormones and GLP-1s, like every day, right? There's all sorts of articles and posts and things on all our feeds about these two hot topics for us in middle age. So, yeah, so MHT, menopausal hormone therapy, is not a weight loss medication, right? Despite what we might be reading and seeing and hearing from others, it doesn't directly cause weight loss. Now, we touched on the physiology and what's going on. So, if someone is in the menopause transition and they're a candidate and they're on MHT and their sleep is getting better, they're having less joint pain, they're not having as many hot flashes and night sweats, they have more energy, their mood is better, that person might then be able to say, hey, okay, yeah, let's start looking at, my lifestyle tools, my nutrition, my exercise and things like that. So they can, actually come up with a new way, right, of,
Right,
of dealing with these changes. So in that sense, it can certainly help indirectly. And it does help. Women who are on MHC tend to gain a little bit less weight over time. They tend to have less visceral fat
okay.
than people who don't. So we do notice some of those things. Now let's talk about GLP-1s, right? So there was actually an interesting study. It was a small study last year where they looked at women who were postmenopausal. Half of the entire group was on semaglutide, which is also known as Ozempic or Wegovy, and half of those people were also on MHT. And they noticed that the people that were on both together had even better results. Like everyone had great positive results, but those people had even better results. So it makes us think that there is a synergy, right? Because we know weight gain, there's a lot more to it. It's multifactorial,
Right.
and hormones do play a role.
Right. Oh, that's great. So one thing I have heard a lot and have spoken about is this idea of muscle preservation, which you laid out with your pie chart, bones sort of getting smaller and weaker and muscles getting smaller and weaker. And for many using a GLP-1 medication, this is a big deal. And even for some
Mhm.
people who um, are really committed to exercise as a lifestyle mitigating factor, are hesitant about GLP-1s because they've heard you can lose some muscle along with the fat. So I understand this doesn't have to be so, right? You may lose a little. As you lose fat, you're going to lose some muscle, but you're not going to whittle away to nothing. You do need to work on preserving that muscle. So what does that look like for people?
It's exactly what you said, right? When we lose weight, we do lose some muscle. That's just how it works. Now, before, during, and after, right, using a GLP-1, which GLP-1s, by the way, are not a quick fix and they're not
Mhm.
easy to take, but they are a tool that can be life-changing and can really improve the health of the right people, the right person that's on it. So it's, remember, we have to think about these as long-term solutions. So when someone is thinking about losing weight or wants to reach a healthy weight for themselves, guess what we recommend? Having the most optimized nutrition, right? So you're getting in the right amount of protein, you're getting in the right amount of fiber, you're hydrating, right? So that's that. And then we also recommend movement, right? So in midlife, we notice for women going through the menopause transition, weightlifting, weight training becomes really important for our bones and our muscle, as well as it helps with so many other things, right? It helps with blood sugar regulation, right? Because the higher your muscle mass is, the better that helps. Um, so these are things that we would recommend anyways, right? Get
Anyway,
good sleep, manage your stress. So we would say that anyways. So nothing really changes, right? So we just want to make sure that, people who take this realize like you're going to have to keep doing all the things. And if maybe you weren't doing them before, like now you've got to double down. You've
yeah,
got to definitely do it, right? And then you've got to continue doing that, right?
yeah.
It's almost like a change in the way of life, right?
Hmm. That's helpful. Yeah. I think I look at it, sort of including a GLP-1 in one's lifestyle as uh like a commitment to longevity, but also just sort of understanding that, like, MHT, for example, or some other medication that you're using that's going to kind of help your body help itself. It is something that is long term, and also that you want to what am I thinking to say here? You want to understand that it's an opportunity. It's like other opportunities, like perimenopause. You explained is an opportunity that you want to like dig into all of the stuff that matters anyway, whether you're using a GLP-1 or not. But certainly, if you are, it is a time to sort of like double down into all the lifestyle principles that you know to be in your best interest, if that makes sense.
Absolutely. I agree
I
with
want
that.
to turn to questions that have come in now for a moment.
Sure.
Um, First one is, thank you for the seminar. Thank you for being here. As I've aged, I'm now 58. I've gotten tiny red veins on my cheeks. Is that rosacea? And does the estrogen help take that away?
So that's a great question. Rosacea, really there's different types of rosacea. So you definitely want to go in and be seen. There can be like a certain pattern to it. So there can be some increased vascularity that may or may not be rosacea, right? So I would say definitely make sure you see an in-person, your primary or a dermatologist to really make sure to get that diagnosis. And then to answer your question, you know, so I can't say directly that, using an estriol cream is going to take those away. It depends on what that is.
Right.
Right. As we try to treat things from the inside out, we can't say that, taking hormone replacement therapy or applying a cream is going to just completely, reverse something and take it away, because it is a process, a physiological process that we're
Mhm.
not completely reversing. I don't
Okay.
know. I hope that helps.
Okay, okay. The next is, why does the Eva mist make my breast feel swollen and sore like when you're pregnant? I only use one pump per day and about every other day. And then someone here on the call actually responded and said, I just started using Eva mist because the patch made my breast swell to the point where I couldn't sleep. I even dropped the dosage and
Hmm.
it still had that
Mm-hmm.
effect. But the Eva mist took that away. However, I also want to make sure I get the health benefits, so I take one spray and alternate with two. And she goes on, can you explain why that might be happening and what a solution may be?
Sure. Yeah, so so appreciate, everyone sharing their experiences, that because that helps all of us learn. So any type of systemic estrogen can actually cause breast tenderness, a feeling of maybe engorgement, pain, even for some people. It's different. And I just want to share too that we have different forms of estrogen, right? Like systemic estrogen. We've got the tablet, we've got the spray, we've got the gel, right? We've got the patch. And so our body actually absorbs differently, so some people may notice like I tend to feel better on this form versus that, or that one worked for me and this didn't work for them. And it's a completely different answer for their neighbor or their friend. But what I would say is, and I also want to share like progesterone can have an effect as well on the
Okay,
breast as well. So it usually goes away in the first like 3-ish months. But if it's
okay,
persistent, if it's bothersome, obviously we don't want anyone to suffer. Definitely let, your clinician know. Sometimes depending on what they say, sometimes if the other symptoms are being balanced and it's really helping you, you might want to think about asking about an evening primrose oil supplement. Sometimes that can help people. Sometimes cutting down on your caffeine because that can cause pain in the breast and tenderness as well. So
okay.
just letting them know.
So let your clinician know for sure. You may need to try a different modality. You may need to tweak your doses. The reason I want to just like hover here a little bit,
Yeah,
because
of
I think
course.
so many people also don't realize that those modifications are available to you, right? And that if
Yeah.
one thing isn't working, it's important. It's a commitment. It means kind of dialing into, let me see if I can get to the thing that's going to work best for me. So it does take time, but that it is available, and you should
Yes.
consider that tweaking and changing and seeing what is really best for you.
Yes, I agree. You don't have to suffer, You don't have to suffer. We can figure it out.
Okay. What can you take or do to treat symptoms of fatigue, weight gain, if you cannot take oral estrogen due to lupus and blood clotting disorder?
Okay, so really great question. So first of all, we talked about weight and hormonal replacement therapy and how we cannot say that that will help with weight gain, right? Or cause weight loss. Now, for someone who has lupus and a blood clot, a history of blood clots, I mean, I wouldn't say that, hormone replacement therapy is completely off the table. I think it's a nuanced discussion. People who have lupus are already at a higher risk of having blood clots compared to the general population. So that needs to be considered. Um, Once you've had a blood clot, that does raise your risk for having blood clots again. But again, there these are situations where I feel like it'd be really great to have a discussion with the other clinicians that are part of your medical team and kind of think about, obviously oral estrogen would not be uh, a recommendation because that does go through the liver and it can activate clotting proteins, which we wouldn't want to do that in someone who has a risk of blood clots. But there are also transdermal options, that don't further increase your risk. So it doesn't mean that you would never have a risk, but it doesn't increase your risk further than whatever your baseline is. So again,
So,
I think
okay,
it takes, a very, focused conversation.
with a menopause specialist.
Yes, with a
So,
menopause specialist.
so transdermal meaning the patch, the gel, the spray, may be something that's actually available to
It
this
may be, and it
person.
really depends on that person's individual health history, what's happened. And I think it would really be great to coordinate care with their other specialists.
Great. Okay. This next question is, I've been losing hair a lot lately. I am on antidepressants, Prozac, although the doctor says it has nothing to do with it, but I do have oversized ovaries. And then she goes on to say there's a bald patch forming at the front and in the middle of my head, kind of like how men have it. The sides and
Mm.
back of the head have hair, although those are thinning. Is oral minoxidil an option for this person?
So I Well, first of all, my heart goes out to this person. I mean, nobody, likes to see that, and that must be really hard and distressing. What I would say first is if they feel like it might be a male pattern, if they're wondering if it's their medication, the first thing I would say is to let your, clinicians know, which it sounds like they did, and also getting like some baseline blood work done
Mhm.
just to make sure there isn't any
Yeah,
other cause, right? There can be other causes as this person is wondering about. It can be from medication, it can be from thyroid, it can be from a nutritional deficiency, and there can be other hormones at play, not necessarily just estrogen and,
yeah.
progesterone and testosterone that we typically kind of focus on. And so I would really want to understand, like, do we need to really uncover, like, is there a root cause going on? What else is happening with their health?
I appreciate that. The sort of the reminder that this isn't for everything an estrogen, progesterone, testosterone conversation. We have a lot of other hormones at play in the
Yes.
body. And if you are, um, you know, dealing with a symptom, there very likely is a root cause, and so further testing is likely warranted. So that's great. Thank you. This next question, since starting HRT, I've totally gained weight in my abdomen. I've read that using hormones isn't supposed to cause that, or is it? But why are so many women getting that same belly fat, and what can we do? Is it a sign of too little estrogen? And she says, P.S. I've been on hormones a year at the end of this month. So she's definitely put in her time around MHT.
Absolutely. So, one thing we have to remember is the menopause transition is long. Right? I mean, we're saying, like, right, the average age of menopause in this country is around 51. So that means no more periods, the ovaries have retired, can't get pregnant. Okay. And so the average range of age is like 45 to 55. And then we're saying that perimenopause can start up to 10 years before that. Right. So that could literally be in your late 30s or early
Mhm.
40s where things are starting. So I just want to remind people that, this change in physiology that we talked about earlier, where, we are putting on weight and we're putting on weight in the midsection and the fat deposition is happening. It's happening probably well before you seek out care, right? Like in a subtle, small way,
Yeah, yeah,
right? I mean, because sometimes that's, something gradual that you're noticing. So I mean, none of us have a crystal ball, but to me, that is happening for most of us. So I don't, you'd have to think about whether it's directly from the hormones, because these hormones, again, that you're on that we're talking about are supposed to be very similar to what your body naturally made,
right,
right? So we're kind of giving you something that's very similar to what your body used to run on.
right.
So we typically don't see that estrogen in and of itself causes weight gain or weight loss. Now, some people will notice a change on the scale when they first get on MHT, and sometimes that can be water weight related, a little bit more to the progesterone.
Okay. So it can cause some bloating, and
It
then
can cause some
the pain.
bloating. It could cause like the number to change. But remember, more than the number on the scale, it's really like what's your body composition? How are your clothes fitting you? And I have had so many patients who the weight on the scale isn't even necessarily changing. They're just like, what, why do my clothes just
Right,
not look right or look the way they used to?
right,
Right?
right. Things have really shifted. And I
Yeah.
think sort of understanding too that, to your point, that there can be this conflation of um, weight uptick and maybe recent usage or recent introduction of MHT and age and metabolic shifting, like all of that can kind of happen. And it may have had this sort of slow incremental uptick, but now everything's sort of meeting in the middle, and it's
Yes, it can kind
literally
of.
meeting in the middle.
Right. It could kind of feel like it's all happening at once. And also for the person that, very kindly shared this, there can be other things going on too, right? Like we can have more things going on, than
Yeah,
one thing, right? Like there could be like thyroid stuff going on? What's your blood sugar like, right? Like things like that. Sometimes stress,
Just
I
gonna ask you
mean,
about
poor
that.
sleep, right? All of these things, like everything's happening at once, which can make it so challenging to discern like what's coming from what.
Right, right. I often encourage people in support groups to keep a journal,
Mm,
and which can be a pain for some people, but I'm talking like just bullet points to kind of help you gauge that point,
right.
what's coming for what and when. You do a lot of work, Dr. Gandhi, around stress mitigation, and I wonder if you could kind of um just sort of hover there a little bit and let us know how important it is to kind of dial in on what's in the way. Stress can certainly impact our weight. I feel very strongly that, stress impacts everything, arguably turns the volume up louder on everything, including perimenopausal symptoms. But can you just talk a bit about that piece and how we might give it more attention?
Absolutely. Stress it's like stress is like a boring word, like, oh, stress reduction, right? But it's so important, right? Our emotional stress affects our entire body, our physiology. All of these hormones are interconnected, right? Like you said, when we say the word hormone, we just kind of think like estrogen, but there's actually so many hormones. There's like cortisol involved, our thyroid hormone. There's so many hormones. Our body is full of different hormones, and they're working, in this hopefully in this beautiful symphony, like, arrangement that kind of goes away during the menopausal transition. It feels like, right? The symphony, the tune changes. Bad joke. But I guess what I mean to say is that, it is really important to look at it, right? I mean, we know as a society, our anxiety rates have just increased, right? Like even since the pandemic, even in young people, in children, right? So it's definitely worth talking about. And when it comes to kind of stress, people cope in different ways, right? And so we're even taught to eat our feelings. Like when you're young and you're like, someone's crying or they're having a bad day, let me get you an ice cream cone. You want some candy, right? Like some of us, that's what was modeled or told to us. Do you want a treat, right? Treats were always sweets. It
Yeah,
wasn't a sticker. It was something
right,
sweet. Like, don't try to
right.
give me a sticker for that. But so it's just kind of, looking at our patterns and the way we've coped and managed stress all this time. And that's why I say this menopausal transition is an opportunity. Are the symptoms miserable and not fair? Absolutely. They are just awful sometimes. And I want to tell you, I'm with you. I am a
Mm,
perimenopausal doctor, right? So I'm up and down and the peaks and valleys too with
yeah,
everyone, you know. But it's a chance to just look at everything and say, hey, I notice I do kind of start rummaging in the pantry on bad days or when I had a really bad night's sleep. Huh. You know, just noticing awareness is the key to any change in our life. And I also think, giving our minds a break, right? These minds, their job is, to think, right? And to focus. And most of the time, if we ponder, our thoughts have to do with the past or the future. What
right.
happened? Is it going to happen again? What's going to happen? I hope that doesn't happen again. I can't believe she said that, right? They just about, they're rarely centered in the present moment,
Yeah.
right? Rarely, right? And so I recommend integrating some form of mindfulness into your everyday, even 5 minutes, right? And so years ago, if you would have said, what is mindfulness? I would have been like, I don't know. That's a really esoteric term and it's intimidating. It really simply means just being in the now, in the moment. Like we are together, all of us, right here, right now, and just being present and telling ourselves, like, wow, I get to not solve any problems. I get to just focus on this conversation and be here right now. And so for me, the three things that I recommend in my practice that I think are kind of easy to integrate and implement, and they're all scientifically proven. The first one is gratitude journaling, writing down 3 things that you're grateful for every day or talking it into your phone. And you've got to get specific. You can't say, "Oh, that I have a roof over my head. Oh, that I ate." Of course, those things are really important. Of course, there's many people in the world who don't have that. It doesn't mean, we're not taking anything away from that. It's just that the brain, in order to really feel the health benefits and feel that gratitude, needs specifics, right? It gets bored. So doing that, can literally rewire, um, and offer neuroplasticity, right? And so we know there, I could do a whole talk on the health benefits of gratitude, right? So another one is breathing, like 4-7-8 breathing. So you can even Google it. So you inhale for 4, hold it for 7, exhale for 8. Doing that for 5 to 10 minutes can lower your cortisol levels. It can lower your blood pressure, your breathing rate, your heart rate, right? Another one is meditation, if that means using, there's all these apps and they have like free YouTube guided meditations, all of those kinds of things. I even offer to my patients, I'm happy to jump on a Zoom and help them with it, in my private practice. So, there's lots of ways to integrate it. And I find if you kind of do this before bed, it often helps improve your sleep quality and,
Which will improve
really helps your
everything else.
mood, right? Sleep is the first thing that I really hope to help make better.
Thank you for all of that, Dr.
Of
Gandhi. I really
course.
appreciate it. I'm going to turn back to questions now.
Yes.
How to create a perfect diet, and what are you supposed to eat to be healthy and grow muscle?
Great question. So remember that we are seeking optimization, not perfection, right? And what works for one person isn't going to work for other. A few weeks ago, I did a little post on protein powders, and I noticed, like, I was trying to, increase my protein in my breakfast, and boy, I tried a few different kinds and I felt terribly afterwards, just lousy for lack of a better word. And it was a great reminder, like just because it works for someone else doesn't mean it has to work for you. It may
Right.
not work for you. We are unique individuals. So, but to that person's point who asked this great question, I think prioritizing hydration. So, as long as you don't have any major kidney or heart problems, I mean, getting in like 64 ounces of water every day is really important. Protein, for the most part, in a middle-aged adult that doesn't have any major medical problems, focusing around like 90 grams of protein is a great idea. And then you want to be choosy about those, right? Plant-based is great. If you're going to have, meat, make sure you're choosing like a lean, healthy, good quality meat. And then, be careful with these protein powders. See how you do with them, right? Because that protein bars and protein powders and just protein in general is just like a whole thing now, right? And then
It is.
fiber, right? Fiber is, most of us, at least in the US, like we don't typically get enough fiber in our diet. And so I think aiming for 30-35 grams is great. It helps you feel full, helps regulate the gut. I kind of tell people focus on a low inflammatory diet. So an example of that is the Mediterranean diet. Um, and, just kind of thinking of those few couple things is a great place to start. And
I
just
think
do
what,
your best.
yeah, just do your best. I think what's nice about the Mediterranean diet too, just to sort of like familiarize yourself with in principle, is that whether you're taking a GLP-1 or not,
Hmm.
it's sort of like a best practice kind of diet, right? Lots of plants,
Absolutely.
lots of fiber,
Yes.
grains, beans, legumes, some fish, some high quality organic, what, I guess meat. I don't know how much meat shows up in the Mediterranean diet, but
I mean,
um,
I think it's what you said. It's like the variety is key, right?
variety.
Like it's,
Yeah,
and really all of this, what all this is about is making your gut happy, gut
right,
health, right?
right.
So your gut is 27 feet long, approximately, loops, right? And I've been scrubbed in surgeries and held them and see them. It's amazing. The human body is amazing, right? And the absorption portion, they say, is around the size of a tennis court. So it's really impactful for our health, like making sure it's running right, it's working. And then the gut and the brain have this amazing communication through the vagus nerve. It's kind of like a two-way highway, right?
Mm.
So some people call the gut our second brain. It influences, what we eat, what we crave, even our mood. The highest number of serotonin receptors are found in the gut. So
Right.
it's just really important to kind of remember, like, food is nourishment, food is nutrition, food is fuel, right?
Mm.
I really think this midlife transition is a chance to redefine your relationship with food because it gets messy, and especially for women, depending
Mhm.
on how you're raised and the messaging you got, and and where does exercise come in, and oh, I ate bad so I need to exercise, or it's a coping tool or it's a punishment. I mean, just all of this, we get to clean up so much in midlife.
Yeah, yeah. The opportunity, to your
The
point earlier.
opportunity, the
Um,
opportunity.
can you talk about melasma that develops during perimenopause and treatment options? This one is a big one for people, and I know that I'm going to be speaking with a dermatologist, and this is going to be a lot of that conversation. But can you tell us anything about it, Dr. Gandhi?
Yeah, so melasma, there's a few really important things to consider is, heat, hormones, it's just it can be really tricky, the treatments as well. For some people, oral estrogens tend to kind of cause that. Some people develop what they call the mask of pregnancy, so
Yeah,
melasma, right, during that time. So it's important to consider. And you also can't use all of the typical things that people might use for
right.
hyperpigmentation and discoloration. So it is tricky. It's treatable. It takes a lot of diligence, a lot of hard work, but my heart goes out to people who have it. And I think it's great that we're going to have a dermatologist focusing on that more
Yeah,
because
yeah, it's a big one and it's a
it's a
lot to
big
unpack,
one.
and you
It's a
really
big
do
one.
want to sort of get the expertise, I think, of somebody who looks at skin all day long and
Yes.
so stay tuned for that one. Um,
Yeah.
Somebody asks if taking testosterone reverses the effects of oral minoxidil. Are they contraindicated?
No, they are
Okay,
not contraindicated. And no, it doesn't reverse the
okay,
effects. Good
okay.
question.
This person who's joining us is 17 and says, I have acne. I try my best to keep my skin clear, wash my face 2 times a day, apply creams, but it's still there. Is there any food that would help make my skin clear?
Oh, such a great question. And, I remember my 17-year-old self. I had so much acne, so much hyperpigmentation. It was really tough. So you know, this person brings up a good point. What's a relationship between our food intake, our
Yeah.
gut health, and acne? And there is a relationship, right?
Mhm.
So, I would say being careful of sweeteners, sugars, um, high glycemic index foods, right? Things that make your blood sugar bump up. So, really curbing that, right? Even dairy for some people can be
Yeah.
inflammatory, right? So, just kind of considering those couple things, and then stress reduction. If you notice it's hormonal, if it's related to your cycles, talking to your doctors about that is really important. I can't say that from the studies, from what we know, that there's a food that directly helps, but I think there's foods to avoid and stay
Yeah.
away from,
Yeah.
and then yeah.
No, I'm sorry. I think that's such a good point. There are foods to stay away from. Dairies, I know, can be a big one for many people, and so can sodas if you are a soda drinker. But I just wanted to,
Sugar.
this is anecdotal, but
Yeah.
I was around 15, 16 with really bad acne, and I started using Retin-A or tretinoin,
Hmm.
and it was like remarkable.
Right?
So,
Yeah.
if you are somebody who's struggling, it is a prescription. You do need to speak to a physician who can, you know, determine that that's a safe product for you to use as a young person. But, and you also need to know there's kind of like things can get a little worse for a little while before they get better. But once they're better, they're better. But you definitely want to be using sunblock as well. So for whatever.
Yeah, no, I think that's so great. I mean, there's definitely some certain things that, I would say absolutely, like making sure that you have a cleanser that, maybe has salicylic acid in there, right? Having maybe some benzoyl peroxide for spot treatment. Retinoids, so important. Retinoids are great, for many, many reasons for in midlife, as well as they help with acne. They help with the hyperpigmentation
Yeah.
from it. That's so important. And then, sometimes some people might need a topical product that has antibiotics. Sometimes, you might need to kind of do a combination of things. Like if the creams aren't working, are you using now medicated? And then maybe you go from that. Do you need some orals? So, just working through all of those steps is really important.
Okay, thanks. A few more questions ahead of
Yes.
us here. This person says, I have permanent pain in my upper back, neck, and joints. Is this a symptom of
Mhm.
menopause?
So I'm so glad that they brought this up. I mean, it's hard sometimes to discern, right? Because in midlife, you're like, well, I am sitting at this computer all day. I mean, I don't know if that person is, right? But many of us are on a screen or sitting like this or driving all day. Many times our stress and tension is stored. These muscles can be very tight here. So could that be, mechanical? Could it be hormonal? Well, there's something called the musculoskeletal syndrome of menopause. And
Mm,
if anyone here probably knows Dr. Vonda Wright, who's amazing, right? Her team put out a paper, I believe
mm,
it was last year, and really detailing it, right? So women notice during this menopausal transition that they have joint pains and muscle pains that sometimes seem out of proportion with their activity or their usage of those. So could it be playing a role? Yes, it could. Is it the entire reason and cause? Hard to say, right? Because it depends, because those are areas that, even for example, like men, many men would complain that they're very tight up there too. But if you think it's more, I mean, I always tell people, trust your gut. You've been in this body for a few decades by now. You've been through, periods. If you've been pregnant, you've been through the ups and downs of those hormones. So you kind of have an idea when you think it's
right.
hormonal.
Yeah. Can you combine oral with topical estrogen? For example, pills with a patch or gel? This question comes up a lot, actually.
So when we're talking about estrogen, like, a pill with a patch of the estrogen kind of thing, so I will say not everyone fits fits in a box, right? In terms of, you know, just going through the standard protocol. There isn't even like a standard agreed upon protocol, right? Because everyone is so different in terms of their absorption, through a patch versus a pill versus a gel. Uh, you know, I do think that I do see that, in certain situations. It's not like the most common approach, but sometimes I have seen that some patients benefit from that.
Okay, so speak to your
It's
practice.
very individualized, right? It's
Yeah,
very individualized.
okay. Can a 28-year-old with hormonal issues take estrogen pills? This is a big question.
Yes, and we do see, sometimes people uh like this person that's asking the question come through on the platform, so our focus at Alloy is more on menopausal health and the transition. So there can also be other reasons, that a person is having changes in their hormone levels, maybe at an age that might be younger than expected. So I always tell patients it's really important to see in person clinicians, get a solid workup, right? Just because on our platform, we are messaging only, right? So it is important that it could be limited, our ability to coordinate care, but I think really getting a full workup is going to be key.
Okay. How do you know if your body needs progesterone as well as estrogen? Can you shed light on why you need progesterone, who needs progesterone, and so on?
Absolutely. So, if you have a uterus and you are taking systemic estrogen, you absolutely must be on progesterone. And the reason is because estrogen can cause thickening of the uterus's lining, and that thickening over time is a risk and can become uterine cancer, right? So it's really important that if you have a uterus and you're on systemic estrogen, I'm repeating myself, you must be on systemic progesterone.
Okay.
Now,
And
if you don't have one, it's optional, right? If someone had a hysterectomy, for example, it's optional to be on progesterone. But if you do have one, you need to be on it. It also, the bioidentical progesterone actually also helps with feelings of calmness, it helps with anxiety and sleep.
right. So if you do not have a uterus and you're told you don't need the progesterone, but you're struggling with sleep or I don't know, particularly sleep, you may and are eligible to take progesterone as well.
Yes,
Okay.
in most cases, yes.
Okay. What is the best way to figure out the right hormone levels for each woman given each person's norm is not known, yet the treatment tends to follow standard levels? Is there something better than trial and error? And then somebody responded, I've had a hard time trying to figure out an optimal level for both estrogen and I think she meant estradiol levels in the blood. Is there a reference range for each of those that we can use, and what are those levels? Another popular question. How do I know
Yes.
where I am? How much do I need? How much do I have in me? So on and so on.
Such fantastic questions. So, you know, there has not been an established range that we aim for. There just has not been. And so, therefore, I mean, you see a lot of, discussion and buzz about this online, and it should be at least this much because that denotes that you're getting adequate, bone protection and cardiovascular protection. But none of this has been accepted into a protocol by any medical organizations as yet.
Okay.
Right. And then the reason is because we don't have any solid studies or research that point us towards a range yet. One of the reasons is because each woman has, her different levels of estrogen, but they don't always correlate with the symptoms, right?
Right.
And so it's important to keep in mind during menopause, if you do blood work on someone whose ovaries have retired, they don't make, the hormones like they used to anymore, some of these levels are just going to kind of be low, right? In perimenopause, that's when the ovaries are, working overtime and then they're not showing up to work and they're just like super erratic. So you get this like crazy roller coaster and then the symptoms are all over the place as a result. So, you could get someone if you could do a blood test up here at a peak. And then if you did it another day, you could get them at the valley. Does that necessarily correlate with their symptoms right at that time? Not necessarily. That's what's so tricky about it. And I think, in the rest of our health, we're so used to like doing blood tests and using that information that it's kind of hard even for physicians and clinicians to, kind of refocus and say, okay, what can I focus on? Well, guess what we can focus on? You, the patient who knows herself, who is in her body all day and night, having these symptoms and noticing that something's off, right? And so, what we try to say is let's focus on 70% control of symptoms, keeping in mind that during this menopausal transition, it's not uncommon to need to make, some tweaks and changes.
Okay. And so what I understand as well, and what I think I hear you saying, and what I've heard is that there's really no test that you should purchase or, get pushed into taking that will tell you this is where you are on your perimenopausal journey, and this is how much estrogen or progesterone or even testosterone in some cases although that's a little different, so I won't include testosterone, but certainly estrogen and progesterone you require, but at the same time, as a menopause specialist, you are treating people's symptoms. So you know that they're doing better when they can report back to you, this many symptoms has resolved, or I'm feeling, 80% better with this, something like that. Is that fair?
Absolutely, yes. Yes, I agree.
Yeah.
That's
Yeah, I think that's so important for people to hear, and to Dr. Gandhi's point about having to tweak your dosing or change your method of receiving your estrogen or even your progesterone. Do you take it orally? Are you using it vaginally? Because
Mhm.
each of these little changes can make a big difference in terms of how you're feeling. And once you've gone that year without a period, we know your levels are definitely going to show they're next to nothing, right?
Right.
Yeah. Okay. I had a hysterectomy with ovary removal. Also, I am on the estrogen gel, but the surgeon mentioned I may need testosterone as well. Is there a reason for that?
So testosterone replacement has become a bit controversial depending on your feed, right?
Right.
Um, it's uh, it's interesting. So we're not going to take up all of our webinar time to
Right,
kind
we have
of break
four
that
more
down.
minutes. Yeah.
Yeah, we just have a few minutes. So the way I would kind of think about it is this, so number one, we need to keep in mind is that we do not have an FDA approved testosterone for women at this time. There's, you know, a lot of controversy over why, and some people feel like there is a significant amount of data that supports it, and some people argue that there isn't. In my personal opinion, I'm just my opinion, the way I think about it is this: your body naturally makes estrogen, progesterone, and testosterone. So do men's. We just have different amounts, right? So in some women, not everyone, but in some women, they do benefit from replacement. Now, depending on what state you live in, the regulations, again, it's not FDA approved. It's also considered a controlled substance. So, this is something that I would highly recommend that you see a menopause trained practitioner who prescribes just testosterone about. So, what we do see in the studies is that it can help with HSDD, which is hyposexual I'm having a brain fog moment.
That's
Low
okay.
libido, low desire, right, in women. So it helps with that. And there's some discussion that it actually can have other benefits as well. So I think that would be the key, is seeing someone, now who is trained in that. Now, again, not everyone may need or want that, so it really
Right.
is comes up, it's an individual choice to
Okay.
explore.
Um, One more question, and this comes up often as well. Could you explain the reasoning behind recommending a progesterone break at the 3 to 6 month stage of HRT? In my case, even missing one day tends to trigger bleeding.
Mm. So many, many, many decades ago, and our amazing chief medical officer, Dr. Malone, even has reminded us, like, by the way, we didn't even used to always give people progesterone. I mean, when you know better, you do better, right?
Sure.
And that was a long, long time ago. So now we do that. Some people can't tolerate progesterone. So I have, in rare cases, seen it more in the private practice kind of level, like where, people might, take every 3 4 months, take some progesterone, have a shedding. They're continuously getting ultrasounds to look at their uterine lining, right?
Okay.
um you know I think this person is asking about the reverse, which is like where it sounds like they want to take the progesterone and they're told you have to take a break from the progesterone. Is that
I
correct?
think so. And there are people who talk
Yeah.
about cycling progesterone, and if
Yes.
she's having breakthrough bleeding, when
Mm,
she might cycle or taking a
yeah.
break from it, what's in her best interest?
So I think that's a great question. I think sometimes in the beginning of perimenopause, when you're having somewhat regular-ish cycles, um, it's- periods, I should say, you can cycle the progesterone. So taking it day 14 through 28.
Mhm.
Um, if your first day of your last of your the first day of your last period was day one, right? And that's just in order to help sort of mimic your periods, your regular periods. Now, what happens, as we know, during perimenopause is those periods start to get a little irregular eventually,
Right.
right? They end up actually becoming more frequent before they get spaced out. Not fun, but it happens. So then, then cycling it becomes really challenging. Not to mention, your needs are changing, is what it really means, right? Your levels of hormones are changing. Um, and also, taking it daily might really help with sleep and anxiety that could start to get worse over time. So it just could be a sign that you would benefit from it nightly.
Okay. Okay. Dr. Gandhi, in our closing moment, what would you like to leave people on this call with about, you know, all of it, really? We covered a lot: skin, hair, hormones, weight changes. It's a lot that we sort of, it's a lot of pain points for women in midlife. Certainly, we've heard there's solutions to all of it. Some may take a little while to kind of work, and others don't. But really, sort of, I think one thing I heard from you today is really dialing into yourself, keeping track of how you're doing, realizing you're your own best advocate and you are your own best sort of purveyor of how you're doing and what's best for you.
I love that. I love that. You know, it's not all doom and gloom,
Thank
right?
you for that. Yeah,
It's
it's
not all doom and gloom.
not.
It's liberation, right?
Hmm.
This is an opportunity for us to recalibrate, to reprioritize, to redesign what you want the next few decades of your life to be like, right? When we went through adolescence, we were like, what? Like we were waking up and there was hair and, there was changes and things that were just like happening to us, right? We have to remember we're adults going through this, right? And we have choices. We are in a position to be the best advocate for our health, as well as, for most of us who are probably in this transition, who are kind of part of the movement, it's probably more Gen X and, the millennials have entered, the space as well. And I feel bad. The generations ahead of us, some of the baby boomers,
Yeah,
they weren't, it was so different. The landscape was different. They were raised differently. And then, there was a lot of fear, right?
sure.
So for many of us in the space, we get to be the pioneers and trailblazers, right? So we didn't have maybe people we could call up and say, hey, Auntie so and so, or mom, or, because they just had such a different experience. But we're we're who we've been waiting for,
No,
you know?
I love that.
So
Yeah.
we get to kind of just discover the space with curiosity, with advocacy, so that we can make it not only an amazing opportunity for ourselves, but better for all the future generations. And I like to think of it like, okay, let's zoom out. Let's look at our life. Okay. So human beings, we usually kind of, in the 1900s, we made it to like 40, 50. Well, now our life expectancy, if we're lucky, is like 81 for US women. So if we do the math, that's like 3 or 4 decades of,
A lot of life to live.
that's a lot of life to live, right? What are your dreams? Where do you want to travel? What do you want to learn? What do you want for yourself? Right? So we get to like really look and design a whole new blueprint. And that's what I have a lot of hope for and excitement about is just refocusing and shining that light inward.
I love that. Thank you, Dr. Gandhi, so much. Thank you for your time and expertise
Of
today. Thank
course.
you to everyone who came. Please do take advantage of today's code, Gandhi 20. head over to myalloy.com, take advantage of filling out an intake form about any of these silos we talked about today, whether it's MHT, hair, weight care, skin. You do not need to sort of stay in the where you are if you are unsatisfied with it. So please head over there. Thank you for coming today. And thank you again, Dr. Gandhi.
Thank you. Thank you, everyone. It was such an honor to be here with all of you. Thank you
Thank
so
you so
much.
much. Bye-bye.